Welcome, everyone, for our Grand Rounds, Department of Medicine Grand Rounds in collaboration with Goldrich Institute for Integrative Neuro-Health. So on behalf of the Department of Medicine at EVMS, I am pleased to welcome and thank everyone for joining us here today. We are pleased to host Lawrence J. Goldrich Institute Integrated Neuro-Health lecture today. The Lawrence J. Goldrich Institute for Integrated Neuro-Health was established in 2020, thanks to the generosity of Lawrence J. Goldrich, a Tidewater real estate developer, and his wife, Janice Goldrich. Their goal was to provide comprehensive, multidisciplinary care for patients suffering from neurodegenerative and cognitive disorders, such as Parkinson's disease and Alzheimer's disease. The Institute is named after Mr. Goldrich, who died in 2021 at the age of 98 and had Parkinson's disease, a disease that affects more than 10 million people around the world. The Institute opened its doors in 2023 and provides patient care, diagnostics, and support system for patients and their families, access to new drug therapies and clinical trials, and accelerates research for innovative treatment, care, and cures. I would like to take a moment to recognize Mr. and Mrs. Goldrich for their unwavering commitment to improving neuro and cognitive health in our community. Although Mrs. Goldrich could not join us today, we deeply appreciate her and her late husband, Lawrence, for their dedication and the enduring impact they have made together. Their contributions have been truly transformative, and we are profoundly grateful for what their vision and generosity have afforded to us as clinicians, to our patients, and to the community. And now I will request Dr. Saad Masara to introduce our today's speaker, Dr. Hamid Okhravi.
Thank you, Dr. Qayyum. Before I introduce today's speaker, just a few housekeeping items real quick. For the in-person audience, please, if you have a question at the end of presentation, press and hold the microphone in front of you so that the virtual audience can hear you. For the virtual audience, please post your questions in the Q&A chat and they'll be answered at the end of presentation. CME code will be shared at the end. With this, it is my distinct honor to introduce today's Grand Round speaker, Dr. Okhravi, a distinguished leader in geriatric medicine and dementia research. Dr. Okhravi holds the Alfred E. Abunus Professorship in Geriatrics and serves as the medical director of the Comprehensive Memory Center at the Macon and John Brock, Virginia Health Sciences at Old Dominion University and Eastern Virginia Medical School. A dedicated clinician, educator, and researcher, his work has been pivotal in advancing our understanding of Alzheimer's disease and neurodegenerative disorders. Dr. Okhravi completed his internal medicine residency at Michigan State University's Hurley's Medical Center. He completed his geriatric medicine fellowship at Mayo Clinic. Since joining Eastern Virginia Medical School, he has held progressive leadership roles, guiding clinical programs, research initiatives, and educational efforts to improve the care of patients with cognitive disorders. As a leading expert in Alzheimer's disease therapeutics, Dr. Okhravi is the principal investigator for multiple ongoing clinical trials and serves as the site principal investigator for the Alzheimer's Clinical Trials Consortium, ASTC. He also played a critical role as the Vanguard site principal investigator for the Alzheimer's Association, ALZ Net National Registry, helping shape national research priorities in dementia care. His dedication to advancing biomarker research in Alzheimer's disease has earned him a place on the Alzheimer's Association International Working Group for Plasma Biomarkers, where he helps shape recommendations for the clinical use of novel diagnostic tools. Beyond research, Dr. Okhravi is deeply committed to the community outreach and health equity. spearheading collaborations with the historically Black colleges and universities in the Hampton Roads area to improve dementia care access for the underrepresented populations. Most recently, in recognition of his contributions to the field, Dr. Okhravi was elected to the board of directors of the National Alzheimer's Association, further solidifying his impact on national dementia policy and research. Today, he will be sharing his expertise on pioneering approaches in Alzheimer's treatment, diagnosis, and future directions. Please join me in welcoming Dr. Okhravi.
Well, good afternoon, everyone. Thank you very much for coming here and also joining us on virtual platform. So, and thanks, Dr. Musad, for the nice introduction. These are my disclosures and funding. Needless to say, none of them that goes to my personal account. Everything goes to our institution. This is the outline of my talk, maybe a few minutes behind, so I'm going to be a little bit quicker. First, I will talk a little bit about amyloid hypothesis. And then following that, we'll talk a little bit about original phase 3 results for lecanemab and aducanumab in symptomatic stage of Alzheimer's disease that I presented last year as well. But I'm going to just do a very quick review and as a reminder. And then I will provide some updates on new developments and results related to these two medications since last year. So those are new developments. And then I'll talk about amyloid-related imaging abnormalities. These are, of course, one of the main side effects of these new medications by presenting one of our cases in our memory center. And then I'll move to the main part of my talk, which is about pivotal clinical trials in symptomatic stage, and then in preclinical stage of Alzheimer's. And then I will touch base on near future of clinical trials. And finally, I will conclude by discussing blood-based biomarkers, which I think is quite exciting. There are quite a few different hypotheses related to how Alzheimer's develop. And one of the most popular one is the amyloid cascade hypothesis. This essentially revolves around the amyloid plaques. So based on this hypothesis, for whatever reason, the production of amyloid protein goes up or the clearance of amyloid protein decreases, and then those sticky proteins, the amyloid proteins, they bind together, become two of them, dimer and then tetramer, and then oligomer, and then finally develop the plaques. So the plaques are the first domino of this cascade. And what happens is after the plaque formation, they started, process that will lead to development of tau tangles. And tau tangles are quite toxic to our brain cells, and they will cause brain cell damage, brain cell death, and finally, people become symptomatic and develop dementia. So based on this hypothesis, if we are able to block amyloid plaque formation, we'd probably be able to also block tau tangle formation, and therefore, we may be able to slow down memory loss. So that's kind of the hypothesis. And I'm going to show you about the mechanism of action of these two new medications that we have right now available, how they work based on this hypothesis. What you see here, let me see if, yeah, that works. What you see here, this is the membrane, cell membrane, and then there's a big protein called amyloid precursor protein. And the amyloid protein is derived from this big protein. So it becomes one, and then two of them, and then four of them, tetramer, and then the oligomers. Then oligomers stick together, protofibrils, fibrils, and then finally amyloid plaques. As you can see here, lecanemab works mainly on protofibrils, oligomers, and fibrils. Donanemab works specifically on plaques. And this is how they attack amyloid. And this is what we think what they do by removing amyloid, slow down memory loss. Let's talk about lecanemab again. This is the result of the phase 3 clinical trial that I presented last year as well, very quickly. What you see here, on the, well, let me just first tell you a little bit about this clinical trial. More than 1,700 participants 18 months of trial, lecanemab every 2 weeks versus placebo. The primary outcome was CDR sum of boxes. This is a test that measures both memory and maybe a little bit of a function as well. The medicine got the FDA approval on the 6th of July of 2023. On the left-hand side, that's about amyloid removal. In black, that's the placebo. In green, that's the intervention group on lecanemab. And there is, by 1 year, there's more than 50% of patients became amyloid negative. More than half of people became amyloid negative. By 1.5 years, more than 2/3 of people became amyloid negative. So quite actually strong medicine. But that's not enough, because clinical outcome is always important for us. Here's the clinical outcome. So again, CDR sum of boxes, as you can see here, there's a 27% reduction in or slowing down in memory loss. That probably translates into 5.3 months of time. So then you may ask, what does that mean, 5.3 months of time? This is how I explain to our patients. So if people are on no medication within an 18-month period, if they are on no medicine, and by 12 months, for example, they lose the capacity or capability of managing finances or medications or driving, these medications will keep that for another 5.3 months within the 18 months period. This is, again, the result that I kind of explained before. So now we have a result up to 3 years with these medications, about the efficacy of these medications up to 3 years. What you see here in this graph, this is, again, the original core clinical trial that I just showed you the results. You can see in black, that's the placebo. In green, that's the lecanemab group. Up to the 18 months, which is this line, as you can see, those lines diverge very nicely. Now, after 18 months, up to 36 months that we have data right now available, people on placebo went on medicine. So everyone now here is on medicine. You can see that these two lines are quite parallel. That's quite important because this is one of the concepts of disease-modifying agents. What it means that if we start people on medication later on, they will probably get benefit, but they will never catch up with the first group that we started early on. So this kind of suggests that these medications, at least lecanemab, is a disease-modifying agent. But now here, we don't have any placebo. So what if we bring placebo from another study, which is not really the best way, but of course, that's the only way to really compare. From another study, which is very similar to this phase 3 clinical trial, and that's what they did. They took a placebo from ADNI, Alzheimer's Disease Neuroimaging Initiative, as you can see here in red or pink. And as you can see, that transposed very nicely on the placebo group of this clinical trial. Now, that's up to the 18 months. Let's take a look at this placebo group now after 18 months. And you can see that after 18 months, up to 36 months, they diverge nicely from those two groups that now they are on medicine. So there's some evidence that these medications, even up to 36 months, still work. And probably the effect will be stronger based on what we see here. I just want to remind you that this is not the best way of really comparing because placebo is from another group, right? But as you can see, it's very similar to what we saw in this lecanemab phase 3 clinical trial. This is a post hoc analysis of those subjects that they had low tau level in the brain. And as I said, tau correlates very nicely with clinical symptoms. So low tau level means that those people are very mild, very early stage. They looked at no decline and improvement, comparing the percentage of those people, comparing placebo versus the lecanemab group. As you can see, for no decline in lecanemab group, 76% of people had no decline versus 55% in placebo. For improvement, 60% were in the lecanemab versus 28% in placebo. So it seems that if we actually attack the disease process earlier, probably we can get a little bit better response. Again, this is a post hoc analysis, not really primary outcome. Another exploratory analysis that they did since last year is about measures of patient health related quality of life and caregiver burden within that 18-month period. Remember that all of these people who actually filled out these forms are blinded to the treatment. So they looked at the first one on the left-hand side, that's European quality of life test, and then quality of life in Alzheimer's disease filled by participants, quality of life filled by proxies or caregivers, and then Zared burden interview, which is a caregiver test, a caregiver burden test. As you can see in all of those, patients who were on, participants who were on lecanemab, they had much, much better quality of life, and also the caregivers had less caregiver burden. So that at least tells us that it's not just only people clinically improve, but it actually helps with their quality of life and also caregiver burden as well, which is quite important. Now, in the main clinical trial, the core clinical trial, which was actually for 18 months, people received medications every 2 weeks until the end of the trial. Of course, that was the plan, and based on the FDA approval, to continue forever every 2 weeks. However, they had a study, they looked at 48 months of data and some modeling. What they found was that after 18 months, if we reduce the frequency of infusions to every 4 weeks, the amount of amyloid that is removed on the left-hand side, and also the clinical benefit on the right-hand side, CDR sum of boxes, those are very, very similar versus continuing every 2 weeks, which is actually quite important. As you can see here, these two lines, very similar here, and these two lines here as well, very similar. So now they got the FDA approval in January of this year. We have now patients over 18 months being on infusion therapy for lecanemab, and those people are going to go on every 4 weeks rather than every 2 weeks. So another very nice, I would say, progress in the field. Another interesting thing is about subcutaneous lecanemab. Right now, what we have is infusion. So they need to go to infusion centers, receive the medicine. But now subcutaneous lecanemab, that's in clinical trial right now. So I think probably at the end of the trial, based on the results that they presented, first of all, it has greater amyloid plaque removal by 14%, which is quite interesting. And it has lower systemic injection side effects. It's about 8% compared to lecanemab, which is about 25, 26%. Those are mild, but that's much, much higher compared to this one. And there is no generalized skin rash or hypersensitivity reaction reported. And they have similar adverse events in terms of ARIA-E and ARIA-H. So FDA has accepted the application to review. So maybe a year or two from now, we will have the subcutaneous injection, the shots for lecanemab. That's every week, weekly shots. Let's now move to donanemab. Well, donanemab got the FDA approval after a phase 3 clinical trial of more than 1,700 participants. These are all early stage Alzheimer's, 18 months of study, very similar to lecanemab. And these are donanemab monthly infusion versus placebo. It got the FDA approval on the 2nd of July of last year. Here is the amyloid removal. As you can see, the amyloid removal now with donanemab is much stronger. At 6 months, 40% of people became amyloid negative. At less than 1 year, 70% became amyloid negative. And at 1.5 years, 80% of people became amyloid negative, much stronger, quicker and stronger. And that's really the name of the game. Here is the clinical outcome, the CDR sum of boxes, the same thing. Now here we have 36% slowing in the low tau population, and that actually equals to 6.3 months of gain. Again, remember that for lecanemab, it was 5.3 months. For donanemab, that's 6.3 months, maybe a little bit better. Now, let's a little bit talk about amyloid-related imaging abnormalities, because these medications, they do have side effects. And one of the main ones is the ARIA. So the ARIA, there are 3 different presentations: ARIA-E, edema, ARIA-H, hemorrhage, and superficial siderosis. It's more of hemosiderin deposition in the superficial veins. The main risk factor is ApoE4. How many copies of ApoE4 people have? Here's comparison of these two medications in terms of ARIA-E. Again, the main risk factor is ApoE4. What you see in the middle column here, that's lecanemab. Here, right-hand side, that's donanemab. And of course, here is the percentage of ARIA-E. If you take a look at those people who had no ApoE4, non-carriers here on top, you can see that 1 in 20 people will develop ARIA-E. For donanemab, that's 1 in 6. If they have 1 copy of ApoE4, that's 1 in 10 for lecanemab, donanemab 1 in 4. If they have 2 copies, for lecanemab 1 in 3, for donanemab 1 in 2. So ApoE4 is a risk factor, quite strong risk factor. Now, I want to also draw your attention to down there infusion-related reaction. As you can see, for lecanemab, that's 1 in 4. For donanemab is 1 in 10. For donanemab, that's less. So now, this is the incidence of ARIA-E. This is a case that we had in our center that we started treating. This is a 77-year-old Caucasian female with mild Alzheimer's disease, amyloid proven by amyloid PET imaging, was eligible based on all the criteria. She was ApoE4/4, so 1 in 3 possibility of developing ARIA-E or ARIA-H. So started on lecanemab on 27th of June. Didn't have any infusion reaction, tolerated very well. Had her 4th infusion on the 8th of August. We do have surveillance MRIs before the 5th infusion. And by the way, every time that they're going to go for infusion, before that we call them and we ask if they have any symptoms or not. No symptoms for infusion number 4. Had her first surveillance MRI on the 13th of August and was scheduled for infusion on the 22nd of August. Came to our office on the 16th, and complained of a little bit of a headache and nausea. Here is the baseline MRI in April. As you can, and these are all axial sequences looking from the top, flare images. As you can see, that's quite actually clean and nice. There is no ARIA. Now here is a 13 brain MRI, the flare, the same sequences, as you can see, the same slices. Now the patient has developed left-sided, that's left, right is left, left is right, left-sided ARIA-E on temporal lobe. This is about, this was about 5 centimeter. And then right-sided occipital lobe, left-sided frontal lobe, right-sided frontal lobe, and the right-sided frontal lobe was 7 centimeter. This is considered as moderate ARIA. Patient is symptomatic, so based on protocol, we have to hold the medicine. We did. We repeated the MRI on 7th of September. The patient didn't have any symptoms. Symptoms are resolved. And as you can see, the ARIA in the left temporal lobe is better now here. In the right occipital lobe is getting better. In the right frontal lobe is getting better. The left temporal lobe remains the same. Patient is asymptomatic. Still, medicine is on hold because we need to wait until the ARIA is completely resolved, and then we can start. Now, that was about ARIA-E. This patient also had ARIA-H, hemorrhage, microhemorrhages. This is the baseline MRI. This is DWI. There is really no microhemorrhages there. This is on 8/13, and they're very small. I don't know if you can see there are kind of dots here, 1, 2, 3 of areas of microhemorrhages. So this patient developed areas of microhemorrhages in August 13. We could detect that. Now, again, at that time was symptomatic. 9/7/2024, patient was asymptomatic, had additional ARIA-H, and also developed superficial siderosis. This is superficial siderosis here now, as you can see. So the patient developed 3 of different side effects related to ARIA. That's in September. Now, still medicine is on hold. This is October 12th. There were more than 10, I think there were 12 new areas of ARIA-H. And when it's more than 10, then we have to discontinue medication completely. So we actually discontinued medicine permanently. Patient was asymptomatic, didn't have any symptoms. And here, take a look at the October MRI for ARIA-E. As you can see, it's quite clean, back to baseline. For the ARIA-H, this is the December 8, 2024. There's still few foci of ARIA-H. Usually ARIA-H stays there, stabilizes. So the patient, again, asymptomatic, but unfortunately we had to discontinue the medicine. Now, for donanemab, just talking about the ARIA, they did a very interesting and smart job. They, as you can see here, this is the standard way on top in blue, standard way of giving the donanemab. Each of these vials here are 350 milligram. So as you can see, infusion 1, 2, 3, we give 2 vials and then go to 4 vials. Now, with the modified titration, the only thing that they did was they took 1 vial from infusion 1 and added to infusion 3. So essentially people got 1, 2, 3, and then went on 4 to see if there is any difference in incidence of ARIA. And here's what it is, which is quite interesting. So on the left-hand side, you can see the percentage of patients who had ARIA. And here's the homozygote group. 57% of ARIA-E. 57% of people who were on standard dose developed on homozygote. They had 2 copies of ApoE4. They developed ARIA versus 19% in the modified dose. So essentially the risk was reduced to about 2/3, which is amazing, just with something very, very simple. And then for the heterozygotes, 23% versus 14%, and non-carriers as well. On the right-hand side, what you see is the symptomatic ARIA. And the symptomatic ARIA was also significantly reduced when people were on the modified dose. So this was presented in October of last year in Madrid at CTAD. And since then, we have changed our protocol. So we offered the modified dose to our patients as well. And we have about, I think, 10 people on donanemab. And I think majority of them are actually modified dose. Now let's move on to current clinical trials in symptomatic stage. Before I review the first one, I just wanted to discuss about blood-brain barrier. Here's actually the brain tissue. Here's the blood vessel. And as you know, there is a tight junction blood-brain barrier. And this is quite important for our brain health. Why? Because this tight junction prevents bacteria, viruses, or toxic material to enter our brain. But by the same token, that prevents 99% of anti-amyloid medications from entering to our brain. So just for donanemab and lecanemab, the amount that goes to our brain is 1% of the concentration. So that's one of the reasons that probably we can improve even the efficacy if we can increase the concentration in the brain. Here's a very interesting study called Brain Shuttle AD. That really means very nicely what they did. So the name of the medicine is trontinemab. So here is the blood vessel. Here is the blood-brain barrier. Here is the brain. What they did, I call it smuggling. I don't know if that's really the right word, but anyway, it sounds like. So with this medicine, they tried to really smuggle around the blood-brain barrier, get the medicine to the brain. How did they do? The trontinemab has 2 components. One is the anti-amyloid, which is gantenerumab. We know gantenerumab didn't really work when it was given to patients by itself. It was not really strong enough. But now here's the gantenerumab. That's one component of trontinemab. The second component is the shuttle. And what this shuttle does, this shuttle has a very high affinity for this receptor. And where is this receptor located? This receptor is on capillary blood-brain barrier. So what happens is that this shuttle will take the medicine, goes and attaches to those receptors, and then we can smuggle the medicine inside the brain. With this technique, we can increase the concentration of the medicine by 8 times. But that's not enough, right? You're always looking at the outcome. And the outcome is about really removal of amyloid. Here's just to show, it's about 160 participants in this study. Now it's actually phase 2 clinical trial. Here's just to show you how effective this medicine is. If you take a look at the right-hand side, left-hand side, that tells you how fast it actually brings down the amyloid plaques. On the right-hand side, by 28 weeks, almost 6 months, 75% of people became amyloid negative, quite negative, because if you take a look at centiloid, less than 25 centiloid is negative, 9 centiloid. This is very strong. For donanemab, by 6 months, that was 40%. So this is quite actually significant improvement. Another one, very interesting, of course, GLP-1s, right? A favorite of everyone. Ozempic, semaglutide, liraglutide, right? So everyone, I think, in the community knows about these medications. Probably half of them are right now on these medications for so many different reasons. But we know about the benefits in diabetes, weight loss, and also heart problems. But there are also some good benefits in brain. There seems to be some effect on prevention of oxidative stress and also apoptosis and neurotoxicity. They also decrease the amount of amyloid and tau based on some evidence, and they decrease neuroinflammation. And they, of course, increase insulin sensitivity and increase the insulin as well. So there seems to be some good cognitive effects. This is a very interesting study. They looked at 3 big clinical trials of patients who were either on liraglutide or semaglutide, either subcutaneously or PO. Close to 16,000 participants, 4.5 years of follow-up. These are all people who had diabetes. If you take a look, you can see that there is a 53% decrease in the chance of developing dementia in 4.5 years. So that's quite interesting. But this is in diabetes patients, right? For that reason, there are now 2 studies going on. One is called EVOKE. The other one is EVOKE Plus. And these 2 studies, they have together more than 3,700 participants. They're very similar. The only difference is that the inclusion of significant number of patients with vascular pathologies in the EVOKE Plus. These are the ages between 55 to 85. Duration is 104 weeks, 2 years, and it's about semaglutide PO. And the readout, look at that. The readout is the second quarter of this year. So essentially at Alzheimer's Association International Conference in Toronto, they're going to present. So who knows, maybe in a few months from now, we may have another medicine from another class that may be effective for Alzheimer's disease. Now, I'm going to also talk about current AD prevention on clinical trials, I'm sure. Let me see what time, okay. So, but before that, I would like to explain about brain volume and size in 3 of our patients in different trajectory groups within the Alzheimer's trajectory. This is a volumetric study from a patient with subjective memory complaint. There are 100 different parts, as you can see here. I want you to pay attention to the red area here. That's the area of atrophy or shrinkage. So as you can see, there's just only one area in a patient with subjective memory complaint. When we do the memory test, everything is fine. Let's take a look at a patient with MCI, kind of a little bit further in the trajectory. You can see more of those red areas, right? More of shrinkage. Let's take a look at a patient with dementia, mild dementia. You see much, much more of those red areas. So essentially, maybe at the stage that we right now treating patients with these even disease-modifying agents, maybe that's late or too late. So if we move maybe a little bit earlier, that could be probably beneficial. So here, what you see is the Alzheimer's disease spectrum starting from the left. As you can see, that's normal age, appropriate age-related memory loss. And then after that, we have preclinical Alzheimer's disease. And those are people who have still no memory loss, but they started having those plaques in the brain. And then after that, of course, mild cognitive impairment, very mild memory problem, and then dementia. Right now, this is the area that we attack, right? Mild cognitive impairment and dementia. probably 40% reduction. You probably need to move a little bit backward at the preclinical stage to get closer to 100%. It doesn't need to be 100%. Even if it's 50% or 60%, that would be good. Even if it's 100%, of course, that's much, much better. That's our goal. So I'm going to give you the information on 3 studies. And I'm so glad that our research team are here. It's just amazing research group that we have. And they're working on these studies so they can keep me honest if I go wrong. So this is lecanemab prevention clinical trial, ages of 55 to 80, funded by NIH and also ESI and philanthropic organizations. The sites, 100 of sites globally, 79 in North America. We are a site. We have the highest rate of African-American participation in the nation. So 40% of our patients are African-Americans. I think we had 21 randomized. I think that number is, because I checked, the day before yesterday, 21 randomized, and now we have 18 or 19 in our randomization. So that's where we are right now. The study started in August of 2020. We joined in, I think, October of 2021, and the randomization closed October of last year. The readout will be 2028, 3 years from now. This is 2 different studies, AHEAD 3. AHEAD 3 targets participants who have much less of amyloid plaques in the brain. In fact, part of those people even are amyloid negative. So that's quite interesting because this is the first study ever attacking people at the very earliest stages of Alzheimer's disease. And the outcome for this study is, of course, biomarkers, because within four years, these are very, very early in the trajectory. Probably they're not going to develop dementia or mild cognitive impairment. So the outcome is biomarker. People are going to receive the lecanemab every 4 weeks for the entire 4-year study. The AHEAD 4/5, 1,173 participants. It's a phase 3 clinical trial. And these people have amyloid positivity in the brain, more than 40 centiloid. And they receive lecanemab for the first 2 years, every 2 weeks, and then after that, every 4 weeks. Really, I would say personalized medicine. And the primary outcome, of course, is clinical outcome. So we are really waiting to see the results. I personally am very hopeful, especially with the results of phase 3 clinical trial of symptomatic group. Just to give you an idea, for this study, more than 20,000 people got screened to get probably 1,600 people. It's quite actually extensive. I think in our site, we had close to 300 people that we screened. Here's another one, Trailblazer-ALZ 3. This is about donanemab prevention clinical trial. Started in August 2021 and finished enrollment August of last year. The objective is whether donanemab can prevent or delay clinical progression to Alzheimer's dementia in preclinical stage. Participants, close to 2,200. And this is a very interesting study because they never did even the PET scan or small tap for inclusion of people. They did just the plasma p-tau217, plasma biomarker. It's quite novel. And that tells you how good this test is. I'm going to talk a little bit later on. So the primary outcome is time to clinical progression, checked by CDR global score. And there are more than 200 sites. The intervention is donanemab infusion, only 9 infusions, not more than that. It's kind of, again, very interesting design. Give 9 infusions and then observe them for a period of time and see who develops mild cognitive impairment or dementia. The expected readout would be November of 2027, 2.5 years from now. Number of screened people, look at that, 63,000 people. Another one, Trail Runner. Remember that was Trailblazer, right? This is Trail Runner. So this is about remternetug phase 3 clinical trial. What is remternetug? Remternetug is very similar to donanemab, but much stronger. Here, what you see with the dose of 2,800 milligram, the blue line. Within 85 days, less than 3 months, they were able to reduce the amount of amyloid plaques by close to 100 centiliter. That's quite strong. And this medicine now is in the trial. The key inclusion trial criteria, 55 to 80 years of age. Again, plasma p-tau, not really CSF or amyloid PET. And people are, the MMSE is either 27 or higher. So again, very mildly impaired or none at all. So this is a prevention trial as well. And the FAQ is the functional test, functional assessment questionnaire. And that is also less than 6, meaning that they have either very, very mild issues with function or not at all. Now, this is the way that they're going to do. People will be randomized to remternetug. Remternetug is subcutaneous, so that's good. It doesn't require infusion. That's another advantage of this study. So they will, as you can see here, they will be randomized to remternetug versus placebo, and then up to 78 weeks. And after that, no medication, and just observe them. And then after finishing, then people who were on placebo can go on remternetug. Very similar to Trailblazer ALZ 3. Now, we will be a site within, we will be an active site within the next few weeks. Am I correct? We hope. So there's a long story behind that. Anyway, so now, of course, prevention is always better than treatment, at least for us, right? And nothing else is better than vaccines. So I remember when I was actually in my fellowship at Mayo Clinic, we had a study, 1972, that was the name of the study, of active vaccination. Unfortunately, that study was halted because people developed autoimmune encephalitis. 18 people died. We had 6 patients. None of them actually died, of our patients. But for that reason, it was stopped. So it was not safe. But now the new generation of vaccines are quite safe. So this is just only about phase 1 clinical trials. There are a couple of medicines right now that are in phase 2, vaccines that are in phase 2 clinical trial. As you can see here on the left-hand side, a couple of them are against amyloid. One of them is against tau. The lower one, the bottom one, that's both amyloid against amyloid and tau. And look at the age here. We're going to really target people at the age of 40, between the age of 40 or 65, quite low, right? These are people who have significant risk factors. Near future trial designs. We talked about moving earlier, but the other thing is combination therapy. Why? Because Alzheimer's, it's not just only about plaques, right? It's not just only about even tangles. There are much, much more into that based on the other hypothesis. I put some of them here. So right now, we just address the plaques, but we need to address other ones as well. The other thing is, when we get older, the pathology is not just only Alzheimer's, like amyloid and tau. It could be other proteinopathies, like, for example, alpha-synuclein or TDP-43. So I think that's another step to really include other co-pathologies as well and medications against them. This has already been started. This is another trial, ACTC, Alzheimer's Clinical Trial Consortium. We are a member, as Dr. Musard mentioned. And this trial is called Tau Platform Design. There are 6 arms. 2 of them, as you can see, that's combination of amyloid and tau. Anti-amyloid medication will be lecanemab. Anti-tau medication, there are 2 different ones. And this will start probably by the end of this year, and we will be a site for that study as well. Blood-based biomarkers. This is really my favorite. Can they be used standalone as confirmatory tests, like what they did in the research that they showed in Trail Runner and Trailblazer? Okay, let's see if it works. It didn't. So for some reason, there are some technical issues, so I apologize. So essentially, the best for a test to be considered as a standalone test is to have more than 90% of sensitivity and specificity. So that's what I'm going to really show with these blood biomarkers, how good they are. Now, unfortunately, I'm not going to have the animation, which helps to kind of, visually understand better. But what I'm going to do, probably it's not yet available. Okay. Yeah, that's actually good enough.
Okay.
That's good enough. So it works, you think?
Yeah, we're going up the PDF for the rest of the way.
Okay,
Right.
okay. So then, oh, there's no, okay, got it. Do you think that we can do it out of slides? No, well, that's fine, that's fine. So now what you see, I'm gonna just come here and kind of explain. What you see here on the left-hand side, that's about CSF approved, FDA approved biomarkers. These are t-tau, p-tau, and amyloid beta. And that's the area under a curve. And as you can see, that's 0.8. It's not bad. But when we combine them together, like a ratio, and that's what we do in our memory center, when we do p-tau 181 over amyloid, the area under the curve goes quite significantly higher. The AUC is 0.94. And that's how we use that in our memory center. Now, here just to show you about the p-tau 217, plasma p-tau 217, it's pretty good at differentiating different types of dementia compared to Alzheimer's. What you see on the left-hand side, these are different types of dementia: Parkinson's disease, progressive supranuclear palsy, FTD, vascular dementia, and as you can see, that can differentiate very nicely. If you take a look at the right-hand side, the blue line, that's plasma p-tau 217, and as you can see, the AUC for that is 0.96. What is it for the CSF p-tau 217? That's 0.99. Not that much of difference. If you take a look at the difference in the surface of those two, like, red line and then blue line, it's not really that much, right? So this test is quite good at predicting, and the sensitivity and specificity seems to be actually over 90%. I'm gonna, because again, I don't have the animation, I'm gonna, okay, now here, this is about commercially available tests. What you see here, there are 7 plasma tests right now commercially available. And in our memory center, within the last 18 months to 2 years, we've been using the last one, which is the Precivity AD2, in a very selected patients, very actually helpful and very accurate. This is a very interesting study. Someone actually looked at this test standalone, the p-tau 217, compared that to primary care physicians and specialists. See how they do. So for primary care physicians and specialists, the information that they had was they had the patient, they examined, they got all the history from patients, family members. They had CT scan reports and also the images if they wanted to see. And they had the memory test, the results of memory test. They came up with their diagnosis. Specialists, look at that, only 73% of time accurate. That's quite embarrassing, at least to me. And primary care physicians, 61%. Look at the test, 91% of accuracy, standalone. That did better than us. It's a bittersweet, right? And I'm really afraid that this test may actually replace us sometime. I don't know. I don't think so. Now, this is the last one that I'm going to put, which is very, very interesting. It's called Drop AD study. So the next step is, oh, I'm sorry, this. Yeah, I have here different, yeah. So Drop AD study. This is about just, instead of going to the lab to have the test done, just sending a drop of blood on a kit to the lab and see if you can get kind of similar results. That's much, much easier, right? So now here is the results. These two on the right-hand side, the middle one and then right-hand side, this is the capillary, the drop of blood, and this is the plasma compared to CSF. The AUC, as you can see, for the capillary is 0.88, for the plasma is 0.98. Of course, the plasma is much, much better, but 0.88 is also pretty good. So this seems to be also the future, that you don't even need to go to, have it checked in a lab. You can probably do it at the convenience of your home. So the key takeaway message that I have here is that, of course, there are emerging disease-modifying agents. New therapies are on the horizon, as I kind of explained. But there's really limited benefits if you have single approach, probably 40% of slowing. What we need really to do is to have combination therapy or come a little bit earlier, start for prevention rather than treatment. And the results of those prevention trials are coming really 2027, 2028. And the other interesting and exciting thing is, as I mentioned, is blood-based biomarkers. This is really revolutionary, especially in the era that we have disease-modifying agents. This is going to make it much, much more accessible for patients and family members. So hopefully we can really provide a better care for our patients and family members. I think here's, of course, our ugly Christmas dress or sweater, contest. This is our memory center and also Glennon Center and research team. And here's just our research team members. And this one is, of course, our website. So if you are interested, there are lots of information actually on our website. So feel free to use that. I'm going to stop here and I'll be more than happy to answer any questions. Thank you.
Thank you, Dr. Okhravi. It was a wonderful talk. Yeah. Any questions from the in-person audience? Yes, please.
Thank you very much for the presentation. I'm actually Salvatore Carbona, one of the new research faculty here in the department. So it's particularly interesting and inspiring to see your presentation. So thank you for that. I do research in nutrition and cardiometabolic. So I have two questions. One is related to the GLP-1 arrays. The earlier studies that you showed in, I think it was a JAMA paper, the curve seems to separate relatively late in terms of Alzheimer prevention. But then the clinical trial that is ongoing, it's a relatively short term, like 1 year. So is the and so I was a little confused there. But is the expectation that GLP-1 array might actually modify amyloid and tau, or are there other anticipated potential benefits of GLP-1 array?
Let me just answer that question first. Thank you. I appreciate the question. So one thing that I want to make sure that you're clear, that study, of course, was in patients who didn't have dementia, didn't have mild cognitive, they were healthy patients, only diabetes. The patients that we have right now for this EVOKE and EVOKE Plus, this is a different trajectory because these are all people who have Alzheimer's by biomarkers. Second, they are at kind of much later stage of trajectory. So probably the time for them will be much shorter. And this is a 2-year study, 104 weeks. So and they did, of course, the calculation, for the power analysis. I think if GLP-1 holds, its truth in terms of efficacy, this study probably will show. It's about like 3,700 participants, quite, well powered.
Awesome, thank you. And then the second question is related to lifestyle. Is there any research related to nutrition, exercise training that might work or might not work? Yeah, thank you.
Thank you. Yes, there's a study called FINGER trial. And FINGER trial was published 2015 or 16. There were 5 fingers, 5 interventions. By the way, that's from Finland. So what they did, that was, socialization, diet, exercise, brain training, and cardiovascular risk modification. There is significant decrease in the rate of developing dementia or cognitive impairment. Now, that was FINGER, and now FINGER is actually worldwide. We have FINGER, China, FINGER, Japan. And then there's one here in the state, which is called US Pointers. And US Pointers is funded by Alzheimer's Association. They finished enrollment in March of last year, and the result will be out there next year, I think. So we have a good evidence, and that's what we really recommend to our patients, especially at the stage of mild cognitive impairment. For dementia, we have some evidence for exercise and brain training, not that much for diet.
Dr. Flemmer.
Thank you. It really was a wonderful lecture, and the medical school is lucky to have you. Something out of left field. In oncology, we use focused ultrasound to disrupt the blood-brain barrier to get medication into the brain. Is that an avenue you would explore?
Absolutely, yes. It's called focused ultrasound. So There's a study. I think probably you folks actually have seen the 60 Minutes. Some of you, University of West Virginia, Dr. Rezai. He's a neurosurgeon, and what we do with the focused ultrasonography is to give the ultrasound focused on, of course, the brain, specific areas of the brain. And then with that, you can open up the blood-brain barrier for 24 to 48 hours. And there's a study giving aducanumab, one of the anti-amyloid medications. That's what Dr. Zay did, 6 months trial, giving with focused ultrasonography versus none. And people who got focused ultrasonography, you can see clearly the clearance of amyloid plaques in the brain in the amyloid PET imaging. It's quite actually, even when you look at it, it's quite impressive. So, but of course, that's a little bit invasive, and we need resources. It's done mainly by neurosurgeons. I think probably 2 or 3 institutions done by non-neurosurgeons. And of course, we know that we need lots of neurosurgeons for lots of other stuff as well. So for that reason, this would be a little bit challenging. What I showed with trontinemab, the shuttle, the brain shuttle, that's quite interesting because everyone can go on those shuttles, the medicine, and doesn't really require anything. It's just a medicine. Patient will get, different types of medication.
Can you have tau protein without having amyloid?
Yeah, so there are several other conditions, neurodegenerative disorders, that you have just only tau. For example, frontotemporal lobe dementia, that's tau. Another one is CBD, corticobasal degeneration, that's tau. So there are others. For Alzheimer's, and by the way, tau deposition in the brain is something that happens when we get older. When we are over the age of 80, you may have normally also some tau in the medial temporal lobe of the brain, but it doesn't really spread. So tau could be just in and of itself present. But in Alzheimer's disease, mainly based on studies, it's first, amyloid and then tau comes.
And then my second question was, for the subcutaneous EVMS, you was given weekly, so there was 14%, I think, greater reduction, but then you're comparing it to biweekly infusions. So do you think that it's really the subcutaneous method, or that it's just more frequently that would be?
Yeah, well, very, very good question. No, this is actually subcutaneous and the reason for that is what happens is when you get a medicine, right, it goes up, and then comes down, right? So when you take it, through your vein, this is very quick. But for subcutaneous, this is much, much slower because you have more bioavailability of the medicine in the brain. That's how we think it actually increases the amyloid removal to 14% additional. It's not just because it's Q-weekly because the amount of Q-weekly is equal to every 2 weeks infusions.
Great. Thank you, Dr. Okhravi. We have 2 comments from the virtual audience. Excellent presentation with very encouraging results and prospects. And then Dr. Weaver has a question if we can answer quickly. Does every patient getting an Alzheimer's dementia workup need an ApoE for check, even if not being considered for novel monoclonal antibody treatment? Is it helpful for other therapies?
Yeah, well, in terms of the genetic testing, we don't really do it for other patients. It's mainly when they are candidate for the infusions. That's what we do. In terms of the workup for patients, also depends. I'll give you an example. If someone actually comes at the moderate stage of dementia and the memory test is quite slam dunk for Alzheimer's, and I'm not going to really do anything different, then probably I'm not going to order the amyloid PET imaging or spinal tap. But if this is something that, for example, I don't know whether this is Alzheimer's or frontotemporal lobe dementia or other types of dementia, and it may help with the management, then I may consider doing that. Yeah, so it depends on the situation, I would say.
With this, we wrap up the grand rounds for today. It was an excellent presentation. Thank you, Dr. Okhravi, and thank you everyone for joining us today.